It's Sandeep speaking. As promised, I want to do a quick review of some of the articles that I've read regarding transitions of care clinics, discharge clinics. There are a lot of articles, and if I had to cover all of them, this review would be pretty long. So, what I've decided is I'm going to break this up into a few chunks at least. So, today's portion of my literature review covers three different articles that I think everybody should take some time to read and review on their own, but I'll at least cover what my big takeaways were and what I personally found interesting from some of these articles. I think the benefit of doing this literature review is that we can have a shared language and shared experience when we go over the same articles. We have the same concepts in mind, and we can make references to these articles in the future as we make decisions for our own clinic. Without further ado, I'll get started with one of the articles I read titled Impact of a Novel Post-Discharge Transitions of Care Clinic and Hospital Readmissions. So right off the bat, I want to say that a lot of these articles make references to and ask the question whether or not post-discharge clinics are really influencing hospital readmissions or not. We will find varying answers as you go from article to article, some of them showing statistically significant reductions in hospital readmissions, and in other cases you'll see that there isn't enough data to make that conclusion. So it's a little interesting and not exactly what I was expecting to find, and we'll go into that in a little bit. With this first article, the title here by Baldino et al. This research was performed in Memphis, Tennessee, and it's a pretty recent publication from 2020 in the Journal of the National Medical Association. Their specific objective was to assess their own TOC clinic that was servicing all patients to see if there was a decrease in readmissions rates or not. And of note, this was a hospitalist-led clinic, which was a little bit unique. So my own takeaways from this article as I was reading it, as they were describing their clinic, they mentioned who was going to be staffing, and that included a hospitalist, a registered nurse, a social worker, and what they called a patient navigator. I found this interesting because it did not include a pharmacist, and a lot of my reading so far has shown that most of the issues that lead to readmissions, well, I shouldn't say most, but at least a significant portion of the problems that lead to readmissions are actually medication related. Not having a pharmacist in this group, I thought, was a pretty risky move, or maybe they were limited in their resources and couldn't include a pharmacist. Either way, I think staff selection and making sure we have a pharmacist in our clinic would be important from some of the other studies I've read. And we'll go into that in a little bit. Next, what I noticed was the hospitalist being the main leader of this clinic. A lot of the hospitalists that I talked to, one of the reasons they got into hospitalist medicine was because they didn't enjoy a lot of outpatient work. So this will be a recurring theme of finding people to staff our clinic and making sure that they're up for doing actual outpatient work and know how to navigate the outpatient system. And they made that a special point in their article, was highlighting that this was a hospitalist-led endeavor. And they thought maybe because hospitalists are involved with the care of the patient in the hospital, having them in the clinic would provide some continuity of care. The next big takeaway that I had from this article was something called a LACE index or LACE score. This is something I did not know of before, and something that I learned. And basically, we can open up this link right here. The LACE index is an index used for readmissions, and it predicts 30-day readmissions or death in patients on medicine and surgery wards. It's a scoring system, and it's for use in patients of greater than 18 years of age. The very first input is the length of stay in days. Next is the acuity of the admission, if it was emergent or non-emergent. And then they have something called a comorbidity index, And there's a scale down here for the comorbidity index. As you can see, a lot goes into it. And then visits to emergency department during previous 6 months. And the number of visits will be quantified here. Overall, the study, the paper used the LACE index to help describe the population of patients that were entering their clinic. And I thought that was really important and an interesting tool that we can use. And it seems like something that's accepted in the literature, something that maybe we want to make sure we're actually capturing these data points. We should be able to calculate a LACE index for the patients that are coming into our clinic. Next, they did a nice outline of their protocol, what they're calling their protocol flow chart. I think that we should definitely develop a flow chart like this to detail how our clinic is going to be set up, or at least the flow from the hospital to the clinic. They explain that this starts way back in the hospital when patients are admitted, making sure med rec is done, making sure that the patient receives detailed instructions. It details that list of patients that are scheduled at the TOC clinic are actually provided to the TOC clinic on the day of discharge, so the TOC clinic knows who to expect. And then importantly, contacting those patients within 72 hours. They use things like text messaging and whatever it means, like constant reminders, maybe mailed letters, to make sure that these patients were aware of their visit. And then finally having that visit face-to-face, and they focused within 14 days of discharge. This study outlined its demographics based on this table, and I thought this could serve as some inspiration for us as we go forward and we try to break down the demographics of our patient population that visits our clinic. So of course they use gender, race, they use the primary care physician status, whether or not the patients did or did not have a primary care physician, the insurance and type of insurance or no insurance. And I thought this was important and something maybe we haven't talked about as much, but they also stratified their patients based on length of stay at the hospital. Those that were there for greater than 6 days and those that were there than less than 6 days. I'll be interested to see a little bit more data on those who had a lengthier hospital stay versus those that had smaller hospital stay, which patients had more readmissions. It might not be as intuitive as we think. And then, of course, the 7-day and 14-day markers seem like they're mentioned again and again in the literature. Those patients who came to the clinic in less than 7 days, or those that came in 14 days or more than 14 days. It seems like the gold standard, and what we can actually get billed for is when patients come for less than 14 days after their discharge. It seems like an important time frame. And maybe those that come sooner versus within 7 to 14 days versus greater than 14 days will have an impact on their readmission rate. And then finally, the LACE score that I've already mentioned. You can see that most of the patients that attended this specific clinic in Memphis had a smaller LACE score, less than 10. And then finally, I want to focus on the last 6 rows here. They broke down their patients into the actual diagnoses groups. And I think this is super important. You can see that a majority of their patients that attended this clinic were COPD and CHF. And throughout the literature, you'll find that these are the 2 main groups that post-discharge studies have been done on, is the COPD and CHF groups. I think that this is important because if we want to find meaningful data and we want to have meaningful assessment of how our clinic is functioning, we might get very, very different results if we look at across all patients versus specific diseases. We might see that our clinic might be working really well for a CHFer who comes back and back again because of medication misunderstanding, signs and symptoms, not recognizing their sign or symptoms at home, versus somebody else who comes in for maybe not as an acute or not as a significant disease state, might not ever go back to the hospital at all. So knowing the disease state, I think, is very important, bottom line. And making sure that we quantify that and define that within our population is going to be important. So then finally, the paper goes on to describe that, yes, indeed, their Pearson chi-squared value calculated for 30-day readmissions was 6.08 in the patients that went to the clinic or were scheduled with the clinic, and their chi-squared value was only 2.28 in their control group, which was not scheduled at their transitions of care clinic, and it was a statistically significant difference. Okay, so this was an example overall of a study that looked at a discharge clinic that was a hospitalist-led discharge clinic, and they did show that there was a reduction in readmissions rates, and they described some of their process for how they set up the clinic, who staffed the clinic, and the demographics of who attended that clinic. The next article was personally my favorite out of the three that I'm going to review today, because it was on its own a review of the evidence that exists out there for post-discharge clinics and hospitalists. So this was performed by a doctor, as Lauren Doctoroff. I wonder if her last name had an influence on her profession. And she did the study out of Beth Israel. It was pretty much a literature review, and it was published in the Society of Hospital Medicine in 2017, not too long ago. But she makes some references to studies that may have been that are a little bit more recent. Actually, she makes references to studies that haven't been completed, that I think actually are completed by this time. Her objective in her study was to do a review of dedicated hospitalist-led post-discharge clinics, of the data supporting post-discharge physician visits, and of the role of hospitalists in these clinics. So, a pretty great article that I think we should all take time to read, and my takeaway points from this article were plentiful. First off, I did not know this, and I think this is pretty basic knowledge that we might all share, but now I know that it was in 2013, Medicare seemed to strongly support the idea of transition of care clinics because they started having management codes. So hospital systems could get reimbursements if patients were if they were having visits within 7 to 14 days of discharge with patients. So that was a billable thing. And so by making it billable, they're kind of sending the signal and a message that we want people to be having closer follow-up, probably because closer follow-up means less readmissions, means less cost. And so that was kind of formalized in 2013, now almost a decade ago. And that kind of got the ball rolling. And it's kind of after this time that a ton of research went in to various institutions, discharge clinics, and their results on readmissions. Now, the article interesting points out next that some of the first studies were out of the VA, and what they described was probably a lot of really vigilant VA doctors and care providers that were seeing patients post-discharge and were catching medical diagnoses and medical problems and actually sending the patients back to the hospital immediately. So the readmissions rates actually increased because of these post-discharge visits. The doctors were picking up on things that weren't addressed during the main admission and sending their patients back. So that was a little interesting. And that was one of the first studies. And of course, it came out of the VA, which has one of the largest medical databases available to us, one of the oldest electronic health record systems in the country. So that was interesting. And then the Dr. Doctoroff went on to state something that I found pretty insightful. A lot of the studies, unfortunately, that are capturing all patients have inconclusive data on whether or not readmissions are actually reduced. It's the studies that focus on high-risk populations and high-risk diseases that are the ones to show reduction in readmission rates. And so congestive heart failure was used as an example where indeed literature review shows that post-discharge visits for congestive heart failure patients specifically does indeed reduce readmissions. But when we look at all disease states and patients of not so high risk populations and high risk populations together, that signal gets lost. And we don't actually see reduced readmissions rates across all patients. And then she gives a counterexample where COPD patients were used. One study showed that there was a reduction in readmission, and another study showed that there was not. So the conflicting results. A lot of what we find from our population going forward and the way we conduct our study and how we stratify our data, I think is going to make a huge difference on what type of results we see and what kind of signal strength we see. This is just making the point more clear that we need to be very careful about exactly which patients we look at as we do our studies, and trying to make sure that we have data to separate out and stratify our patients is going to be really important so that we can find signal, and rather than it getting lost with a lot of noise. I really liked what she did next in the article. She looked at 3 different models of post-discharge clinics that exist out in the country right now, and they've broken down the 3 main types. The safety net hospital model, she focused on a clinic in Texas and another one out in Washington State, I think in Seattle. And she goes on to show that these were the patients that were showing up to these clinics, greater than 50% of them were needy patients. Did not have PCPs, for example, did not have the financial status to attend clinics and weren't really connected with the system. So the main purpose of these post-discharge clinics was really to address the populations that were needy, did not have PCPs, the safety net model. The next model that she focused on were academic medical center models, which I guess we would fall under. And she highlighted the cases of University of California, San Francisco, and also Beth Israel. I think there may have been one other academic center that she pointed out. But basically, she goes in to show that these are clinics that are mostly led by hospitalists. Some of the issues with these clinics is the high burden of care. A lot of these hospitalists wouldn't be able to attend the clinic because they were getting pulled into the hospital at times of high volume. One of the problems with the academic model is just the high strain on the care providers. They have a lot of different duties and tasks to perform. And then finally, the comprehensive high-risk patient solutions. So this was an interesting model I didn't know even existed. This was a model that is not specific to patients who are in need, just like poor patients. This is not in a specific academic center, but these are care providers who follow a patient through every step of their care. They will be at the hospital taking care of the patient inpatient. They will follow the patient to the rehab facility after they're discharged, and they will also conduct post-discharge clinic visits all on their own. These folks are called extensivists. They have a very unique skill set and are trained in a wide scope of practice to ensure care in each one of these settings. These comprehensive high-risk patient solutions are very disease-focused. So one of the examples I think was congestive heart failure patients. That extensivist had received training, or it seems like they had received training on heart failure specifically, and they were able to navigate these patients while they were at the hospital. You can imagine making adjustments to their diuretics and their heart failure medications, following them at the rehab facility, continuing to monitor their physical therapy and occupational therapy and heart conditioning, and then finally in the outpatient setting where they maybe need to titrate the diuretic medications up or down and adjust heart rate medications up or down based on how a patient's doing at home. And then the next part of her article goes on as kind of advice to people who might be off on their own, creating their own clinics, things that we need to consider as we create our own clinic at SLU. So first of all, she covers the return on investment, which unfortunately I think, or fortunately, I don't know, just my perspective that I don't want to get lost in the economics of everything, but that is kind of the driving force behind a lot of decisions that are made in medicine. I want to focus on the patient and center everything on the patient's needs, but we do need to be mindful of the economics of our operation. And so she goes on to the return on investment, making sure that is all this actually going to be worth it? Are we making back? Can we defend our clinic based on its costs and the cost savings that it will bring? And she goes in to say that most of the post-discharge clinics are running under the assumption that by having that clinic, they're saving money on readmissions. And that money saved through lowered readmissions will go into funding that clinic. So then it becomes even more important for clinics to show that they actually are reducing readmissions. And then I think it's even more important for us to isolate the demographics or diseases that are most associated with readmissions so that we can specifically target those populations. And then she brought up an interesting point that another kind of return on investment was just using this clinic as a training opportunity. It's a modality through which we could train hospitalists, or I'm imagining even incoming residents, on a shared perspective on what it means to have discharge clinic transition of care training. It might be an opportunity down the road for residents and fellows alike, depending on the specialty. And then another logistical consideration is sustainability. The clinic, the way we set it up, is it actually going to be sustainable? She made a brief point about saying that a lot of discharge clinics sometimes get caught up on depending on other clinics. For example, imagine a huge portion of patients coming in with COPD exacerbations, and our discharge clinic is then focused on getting them to the pulmonary clinic. Well, that's a huge dependence and reliability on that pulmonary clinic now. And if something were to happen to that pulmonary clinic, it got short-staffed, or one of the attendings is on leave on vacation, that would hamper our functioning as a discharge clinic. So not to be overly reliable on any other clinic or external forces. And then another thing, of course, is sustainability is our staff. Making sure that we have staff that's interested in working in the discharge clinic, has realistic expectations of what working in a discharge clinic might be like, and will be interested in working there for a while. I think that's a huge part of sustainability, is just making sure we have adequate staff that will be there year-round and able to serve in that clinic. Without the staff, you can't have the clinic, essentially. And then the conclusion I thought was very thoughtful. Dr. Doctoroff goes on to say that a lot of the focus is on readmissions rates, and I guess when you have constraints and concerns like return on investment, that is a really important consideration, our readmission rates. But we should maybe think about other outcomes data that can come out of these discharge clinics, such as mortality, patient satisfaction scores, and then just medical expenditure in general. I think if we collect this data on our patients that enter through the clinic, it could be really fruitful and interesting. Next, and more briefly, I covered an article called A Blueprint for a Post-Discharge Clinic Visit After Admission for Heart Failure. So once again, this clinic was very specific to heart failure. That was the population that they were targeting. And they provide some nice graphics, essentially, of what we might want to think about as we're designing our own clinic. So this was by, I think it's Sufer, and at Yale University, in the Journal of Progress in Cardiovascular Diseases in 2017. And their main objective, creating a patient-centered model for a heart failure post-discharge clinic visit. It shares ideas for creating the ideal visit specifically for the heart failure population. So one of the takeaways was this really great figure that the article mentioned: 4 major domains of issues that go into transitions of care: medication management, follow-up appointments, healthcare provider communication, and non-medication signs and symptoms management. We, with our transition of care clinic, are really focused with this domain. And I think that's an important part of all of this, but it's not the only part. As a resident physician, I've dealt with the other portions a significant amount. Medication management, I'm a little passionate about because I've seen it a lot where patients don't know how to get their medications. They have very unclear instructions, or they have reconciliation issues. Too many physicians are telling them too many different instructions, and so they don't know which medications to take at the end of the day. And then finally, transportation issues. They don't have a way of getting to the pharmacy and don't get their medications. The healthcare provider communications is another issue that I've suffered, or I've faced as a resident throughout the last few years. Too few times is the hospital team actually communicating with the patient's primary care physician. And that's something that we can intervene on and take a look at. And then another area that I didn't give as much thought to, which I think is important, is non-medication signs and symptoms management. I think I tell my patients what signs and symptoms to look out for, but I usually kind of say that in 1 or 2 sentences. And it's something that we might want to rethink as a hospital, and especially in residency training, is really making sure our patients understand what signs and symptoms to look out for at home. And there's this idea of lack of self-confidence and self-monitoring that I'm not even cognizant of. That was enlightening to me reading this article, that was a point of focus. I don't consider that my patients might not have the confidence of monitoring themselves. As a doctor, as someone who's gone through medical school, now residency training, of course, I have built that confidence over years, but my patients don't have any medical experience, and we need to remember that. And then last but not least, of course, our domain, something that we're primarily focused on with our clinic, is the actual follow-up appointment. And these are areas of concern that we, I think, need to address and at least think about. Do our patients have a way of getting to their clinic visit? We need to focus on those patients that aren't having appointments scheduled quickly and figure out why that is. Making sure our patients are actually aware that they have the clinic visit scheduled. And then, I guess this is talking about healthcare providers' failure to follow goal-directed medical GDMC. I'm not sure. And this was something that we brought up before, patients unsure of location, making sure that we give very clear instructions to our patients about where our clinic is located so that they can actually get there. And the final figure that the author shared is a follow-up checklist. And I found this really important. You can imagine that for different diseases, you can have different discharge checklists. And I think that's something that we should actually take a look into as we get things started, if we don't already have these types of checklists at our existing clinics. I think this could just provide a general outline, or we could create templates for different disease states, because every disease is going to have its own needs, its own medications, its own signs and symptoms, its own education points, very specific follow-up guidelines. And so they went ahead and for heart failure specifically created a wonderful checklist that makes sure that the provider and patient will go over these points before the discharge clinic visit is up. This involves the actual history taking points, the physical exam that needs to be done specifically, lab tests that provider needs to order at the discharge visit, the medical therapies that should be ordered and reviewed with the patient, multidisciplinary care. So it's not just about the medicines, it's also about diet, exercise, making sure the patient has a blood pressure monitor at home or a scale at home to measure their weights. And then, of course, last but not least, referrals, making sure that the patient does indeed have a visit with the cardiologist or the rehab facility, and the communication with the primary care physician. So that was a little bit about the articles, just 3 articles that I wanted to highlight in this brief review. There are, I think, 8 or 9 other articles that I've read that I will try to break down similarly if this is helpful, or we can just talk about them. I'll make sure to share these articles with you in a PDF, in PDF format on an email, and we can maybe discuss them again. Feel free to contact me personally if you want to discuss them one-on-one, or we can talk about them or set aside some time at our next group meeting. But bottom line, I think there's a lot of literature review to be done and a lot more to learn about what other folks have done out in the community, out in the country with their discharge clinics, and considerations that we should definitely use as inspiration as we make our own clinic. All right, folks. Well, last but not least, I did want to mention, maybe before we meet next time, there's yet one more article that I think would be a great review for all of us. It's an up-to-date article that I'll include in an email, but it's an up-to-date article on hospital discharge and readmissions. This article is pretty extensive. It's about 20 pages, and it goes through a lot of considerations that I think we should all be aware of, studies, calculators and tools, and even national database and tools that we can use as we try to create a clinic using evidence, and just be a little bit more thoughtful about our process as we go forward. All right, folks, once again, I hope this was helpful. I didn't want to make this go too long, but let me know your thoughts and concerns, and I can't wait till our next meeting. All right, see you guys. Bye.